Hello, good afternoon. I'm Dr. Safia Zahir Ahmed, and I'm surgical registrar who worked in Shalamar Hospital previously. Today, I'm going to present me and Dr. Hira Ashraf, another surgical doctor, who's going to present about the topic drain versus no drain in thyroidectomy, refined decision algorithm. I'm going to have a bit discussion about the background. As we know that thyroidectomy is one of the most commonly performed procedure in general surgery, and it is associated with lots of complication if not performed by the experienced surgeons. As William Halsted, one of the pioneers of the thyroid surgery, quoted, the exploration of the thyroid gland for goiter typifies, perhaps better than any other operation, the supreme triumph of a surgeon's art. There have been lots of controversies and evidences regarding the routine use of the drains, as one of the most important factors is the surgeon's fear that prompts the surgeons to place a drain in, especially when the belief is that it recognize early hemorrhage, fear of hematoma formation, prevent airway compromise, and seroma formation. Actually, it's a matter of surgeon's habit or preference more than the habit of a proven benefit, as the emerging evidences have been present, and it defies the routine use of drains in many specialty and best medical practice. It's that to prevent high infection rate, discomfort, and prolonged hospital stay. And in other specialties such as colorectal and hepatobiliary surgery, routine use of the drain and the clinical equity has been questioned, and in those specialty, placement of the drain is almost to none. In regards to thyroid surgery, the incidence of bleeding we know all know is almost 0.3 to 1%, especially it is lower when with good hemostasis. There have been studies which says that drain can assist in recognition of hematoma, while the others contradict that the drains get blocked and clotted with clotted blood and conceal the major bleeding as a result delay in intervention. So our aims were, as we saw lots of discrepancy in the literatures and the prevalent practices that been practiced, especially when they think that there is need for randomized trial. Despite various randomized trials, the main factor still remains unexplored is that the decision making when to place drain and when not to place drain. So we explored those reasons, and we employed a qualitative approach and examined the perception and the scientific justification. With these qualitative findings, we conducted a randomized control trial. Our objective was critically to prove the reasons for placing a drain in following a neck surgery and eventually minimize the gap between the theory and the practice. So we conducted a mixed method study design in which it was in 3 stages. The first stage was a qualitative approach in which we formed a qualitative data collection which comprised focused group discussion and explored the perception and experience of the expert endocrine surgeons for drain placement. Then the second stage comprised of quantitative data collection in clinical setting, especially after the results of the first stage. And the third stage was altogether a decision and proposal for a decision tree circulated among the panel of experts to build a consensus. So the focus group discussion was conducted in a standard fashion with open and closed-ended questions. Purposive sampling of 8 expert surgeons in endocrine surgery who were well trained in endocrine and performed at least 200 thyroidectomies. Then themes, sub-theme, and categories were identified and negotiated between the team members to generate interrated reliability. The quality of the studies was ensured. In second stage, we conducted when we got the results from the qualitative findings, we conducted the second stage, which was a randomized clinical trial, which was double-blinded, elective thyroidectomy with or without drains. Small and moderate sized glands were included, while huge, large, extensive surgery like sternotomy, retrosternal goiter, neck dissections, and history of bleeding were excluded. Our primary outcome was seroma formation and hemorrhage, while the secondary outcomes were postoperative complications. In the third stage, we used E-Delphi technique to build a consensus on defined decision algorithm for drain placement in second round. The results of the first stage was qualitative portion. The theme and subthemes were identified, and to understand the reasons for drain placement, 8 of these experts were participated in focus group, and the factors influenced the decision of placement were explored. So we found that the factors were hemorrhage and apprehension, size and extent of dissection, fibrosis and friability, adhesions and seroma formation. What we found is quite interestingly that one of the consultant thought that conventionally I have believed in drains in neck surgery. It is reassuring. It doesn't hurt me or the patient. Well, in regard to the smaller size, the size of the gland, for smaller size, one of the consultants thought that he may be able to skip the drain, but for larger gland, usually it becomes harder for me to avoid a drain. In regards to friability and toxicity and fibrosis, toxic gland, one of the consultants' opinion was that toxic glands are quite friable and surrounding tissues are also hypervascular and they bleed to touch. Invariably, he would like to place a drain in these cases. In regards to the adhesion, it was interesting that one of the consultants thought that it's very important as there are lots of adhesions in malignant and thyroiditis, and they all lead him to put a drain in. And one of the consultants thought that smaller glands, there were less chances of seroma formation, so drain placement was avoidable. But in extensive dissection, especially in total thyroidectomy for large glands, there is a high chance of bleed and seroma formation if we don't put a drain in. When we explored the reason for the hemorrhage and to prevent it, then we found that the technique and the quality of the hemostasis is quite important, as one of the consultants think that he found few bleeds in his career and they all were related to technical failure and mostly slippage of the ligature of a vein, and he had to always tie it twice. The advantage of the drain placement was reassuring, as one of them said that I'm not sure if it will prevent hemorrhage, but it will keep me calm and reassured. Possible prevention of hemorrhage and reduction of seroma formation. The disadvantage of the drain placement was it causes discomfort and pain and hospital stay. In regards to hospital stay, however, one of them think that he doesn't think that it should add significantly to the patient's hospital stay. Drain placement was avoided in smaller glands and minimal dissection. Whether the drain is needed or used for reassurance, it was interesting that one of the consultants think that it's okay to place a drain in 12 to 24 hours or so, if not only reassuring me, but also reduces the incidence of postoperative seroma formation. In the second stage, when we conducted the first stage, with these findings, we conducted the randomized clinical trial in which we included 212 patients, and we randomized them in equally, and we found that the pain score was higher in drain group, but the seroma formation which needed drainage was higher in patients who did not have drain placement. Other of the factors were insignificant in both the groups. When we further explored the seroma formation, we found out the factors that increases the seroma formation is the size of the gland and the extent of the surgery. So in the third stage, we explored the idea and in the third stage, and we proposed this algorithm in which the gland size were divided into 4 groups, and the small and the moderate ones were the one in which there is less extent of the dissection, excellent hemostasis, no toxicity of the gland, no fibrosis and adhesion. All of these leading to out of the plane. So in these conditions, when these factors exist, then the drain placement should be avoided. As we all know that the incidence of hematoma is low, ranging from 0 to 2.6%, and re-exploration is even less than 1.5. 75% of the patients who developed hematoma in 6 hours and rest in 6 to 24 hours. When we did an extensive literature search, we found that placing a drain in cannot prevent hemorrhage, and the incidence in postoperative hemorrhage is even lower in patients without drain. But a few surgeons still feel reassuring when we place drain in larger thyroid gland, which require extensive dissection. Well, Zahir et al. In his study and discussed that selective drain placement reduces the incidence of postoperative seroma formation. Similarly, we conducted our latest meta-analysis studies which were comparable to the existing literature. The practice of the drain placement is purely based on surgeons' experience, training, and comfort level. The proposed algorithm which we promoted is the decision of selective drain placement with good quality of hemostasis, extent of the dissection, vascularity of the gland, and the huge gland. In conclusion, early recognition of hemorrhage, fear of postoperative hemorrhage, and seroma are the most common cause of to place a drain in, and it should be individualized, and decision should be correlated with the factors. It is safe to avoid drain placement in small and moderate sized glands with good hemostasis when there is no factors involved in seroma formation. Thank you. And Dr. Thank you.